afternoon. I'm Lauren Sansing, the chair of ISC 2025, and I'm here with...
I'm Bijoy Menon. I'm the vice chair of ISC 2025.
And we just came from the main event session on day one of ISC. I think maybe we'll just start out with a couple of the highlights from the trials from the main event. First, we had the MIND study, which was the minimally invasive surgical evacuation of intracerebral hemorrhage.
I did feel that the trial, as was the previous ENRICH study, is showing promise for these minimally intensive tools in intracerebral hemorrhage, and so the trends were in the right direction. I think these are smaller studies, and so overall, I think more evidence needs to accrue. But I'm quite confident that over time, will show that these interventions possibly work.
Yeah. And I'm impressed with the surgical efficacy.
That's
right. They're getting the job done, which is great. I think now we just have to understand the
Yeah.
right selection criteria and who should be evacuated.
Exactly.
It was interesting that the benefit was strongest at 30 days and
That's
then was
correct.
really lost over time.
Yeah, that's something I presume more analysis needs to be done to actually understand why benefits were early and then washed off later. So that was something that I found intriguing.
Yeah, it was intriguing. And then there was the TRACE study about transradial versus transfemoral access for patients undergoing angiography. And interestingly, unlike the cardiac literature, it seems like the transradial access, well, it wasn't non-inferior.
Yeah, this was, I would say I was expecting that the transradial approach would show itself to be similar to the transfemoral approach. So that was a bit disappointing. That overall, the primary outcome, which was the diagnostic ability, was shown to be not just non-inferior, but inferior. However, I do think, the other outcomes, including, I presume there was hospitalization and length of stay, and the amount of time.
The patient recovery time for the
recovery
procedure.
time was better. So I'm hoping that with better training, that this might actually be a approach in addition to the transfemoral approach.
Or again, better devices.
Yeah.
All right.
Yeah,
This seems to be a theme that we need the technology to catch up with the ideas.
That's right. Yeah.
Well, then maybe we should move on to the three big trials on middle and distal artery occlusions.
Yeah.
Do you want to start?
Yeah. No. Thanks, Lauren. So, this was, I presume, the major highlight today. We wanted to know how our field would be approaching patients with distal occlusions, whether we should offer endovascular thrombectomy or not. And so three trials were presented, the distal trial, the ESCAPE-MEVO trial, and the discount trial, which was stopped at interim, and then they presented the results. So what did you feel, Lauren, about...
I have to say, my practice had changed so much after the last endovascular trials that showed such an overwhelming benefit for patients with proximal large vessel occlusions that I was really anticipating a benefit for patients, at least in the M2, region of occlusions with disabling deficits. I was surprised, but the results were remarkably consistent. So both distal and ESCAPE-MEVO showed really no signal towards efficacy in the distal vessels.
And I think there was also, some signal towards harm with both of those trials, with a slightly increased rate of symptomatic ICH and even mortality in a couple of trials. I do think what this does, though, for endovascular thrombectomy, the low-hanging fruit were, patients with large vessel occlusions, and then we were trying to explore the boundaries of thrombectomy treatment with large codes, and now with distal occlusions. And it's quite clear now that distal occlusions, at least with current devices, and we come back to the same story, I think, endovascular thrombectomy is not the standard of care now. And so at least we now know the boundaries of where thrombectomy should be offered and where thrombectomy should not be with the current devices.
And it gives us confidence then that we have equipoise to enroll in future clinical trials.
That's correct, with newer devices.
With newer devices or whatever we learn from
That's
these,
right?
Because these trials now could be studied, and no doubt we'll learn a lot about different signals in different patient populations. You mentioned the sort of, slight signal towards harm in some particular outcomes. It was discount that showed, definitively, right, a decreased odds ratio of a good outcome. And those are the patients that had distal M2 occlusions, right, above the level of the Sylvian fissure.
Yeah.
And that was significant.
I think this was quite informative in the sense that, now we know, at least, in our current practice, what we should be doing with these distal occlusions. Thrombolysis works, so I presume, that's where we should be going. But Lauren, what are you looking forward to the next couple of days now?
Yeah, so there's the one thing that we're really innovating on here at ISC. We started it a little bit today, and we're going to continue it throughout the rest of the conference. And that's using the AHA's specific license for Microsoft Copilot, which allows us to listen in and use generative AI to see what it can do to help disseminate the science more broadly and in different venues. And so be on the lookout for different ways that we try to test this out and see what AI can do for us to help expand the reach of the presenters here at ISC.
You might get a tap on the shoulder. There might be Dr. AI Schwarminator behind you. So,
so be careful. And then tomorrow's main event, of course, there's great results being
Yeah, I'm excited
presented.
about tomorrow. So tomorrow, for those of you folks who are interested in recovery, please look out for 2 recovery trials, the C3FIT and the Transport 2 trial. There's also 2 trials on blood pressure management, the ICH ADAPT study, and a second study which is more focused on thrombectomy, post-thrombectomy blood pressure management. And then for those of you who are interested in CCMs, you will want to know whether atorvastatin helps or not. And so I'm looking forward to all these trial results.
Yeah. And I think the recovery trials in particular, I can't wait to see. There are so many patients living with stroke disability, post-stroke disability. And so, knowing whether we have things that we can offer them will be a real advance in the field.
The third day, Lauren, would be a blockbuster, I presume, with 9 trials?
9 trials, yeah. The amount of science that we had submitted this year was outstanding.
Exactly.
So stay tuned.